It's my pleasure to talk about the topic tonight that a lot of people in their evaluations have been talking about, and it's how to actually do trauma-informed care and what to do when it goes wrong. So really pleased to have our speakers today. And as usual, we do need to go through a few housekeeping items. Next slide. I'm Kathy Scrimshaw, and I think most of you know me. I'll be the moderator tonight. I'm a part-time employee of the Alberta College of Family Physicians, and I actually also have a part-time position with Alberta Health Services in the Indigenous Wellness Corps. Next slide. Tonight's CMN team includes Dr. Leah Phillips, Maya Mudrick, and Jared Leader, and they are paid employees of the Alberta College of Family Physicians. And next slide. And this program receives financial support from the Alberta College of Family Physicians through a Health Canada Substance Use and Addiction Program contribution. It does not receive any in-kind support. Next slide. And so, as usual, to capture your attendance, please click on the survey link in the chat and enter your name and email. We will be using the chat log to collect questions today, and we also will be having two sets of breakout rooms in our evaluation. We heard that people want more time to discuss and to collaborate, so we've listened and we're going to try that out. If you do have a question in the Q&A time, just raise your hand, and you can also ask verbally, or you can type it as you have it in the chat. Remember, when the breakout rooms come up, you have to click the join button in order to get into your room. And an evaluation survey link is posted in the chat log at the end. Please fill out that evaluation. It's really important, and it really helps with our programming. And so now to get to the meat of the introduction, it's my pleasure to introduce Kara Irwin. She's a clinical psychologist, and she's waving to us here, who specializes in trauma and its long-term impacts. And certainly working in community, all of us understand that impact of trauma on comorbidities. She's worked in several settings, and she's proudest of her work in AHS with the integration of a true interdisciplinary mental health team and supports into a primary medical care to make quality mental health supports easily accessible to high-risk individuals in our community. Kara's now doing a PhD in community medicine, and her thesis involves health innovation to manage the multi-morbidity chronic disease clients with a history of childhood psychological trauma. So she also has experience in working with trauma and pain in Canadian veterans. Next slide. Our other speaker is Marie Ferraro, who comes to us from AWARE. Marie is the Provincial Community Engagement Manager for the Alberta Alliance, who educates and advocates responsibly. So they are called AWARE, and she's going to be speaking more about what they do. Marie identifies as a recovered addict and alcoholic and spent nearly 2 decades struggling to manage her relationship with drugs and alcohol. She's choosing to live a life free from all mind-altering substances and understands the importance of harm reduction practices. AWARE actively engages with local organizations to educate and inform them on life-saving harm reduction practices. They provide the drug-using community with comprehensive, low-barrier access to supports and supplies that they need and that they deserve. Both these speakers are passionate and compassionate caregivers in our community. So take it away, Kara.
All right. I'm also really excited to be presenting tonight with Marie because we started the conflict of interest declaration earlier. And while I don't have a conflict of interest, I do have bias. And I'm excited to have Marie to offer a different lens and maybe help kind of manage and offer a different perspective to where some of my bias comes from. So yeah, for tonight, these are our objectives. And basically overall, we're looking to talk about trauma-informed care in addictions work specifically, and how to manage when relationships go awry or when we stick our foot in our mouth or inevitably do things that require a repair lens. So my understanding is you guys have a pretty great background on trauma-informed care, but just to refresh all of our memories, it's the idea of recognizing trauma and responding to the effects of trauma, trying to create space for safer spaces, and that language is specific. I'll let Marie expand on that in a minute here. And overall, we're looking to support clients, not take over for them. So we're looking to kind of establish that internal locus of control and empowerment, and kind of that doing with, not doing for.
Awesome, thank you. So I am really passionate about the term safer spaces as opposed to safe spaces. We can't control how someone is going to like come into a certain space or situation. We don't know what is or isn't safe for other people. And so I choose to use the words a safer space because we're aiming to create a situation or a space that feels right for people, but we can't guarantee safety because we can't control all things. So I prefer the language of safer space.
Awesome. And our little staircase and backpack here is because I like to use the analogy of people have their own journeys through trauma. Some people's staircases are steeper, some are on the edge of a cliff, some have like breaks in between, but the staircase kind of represents their journey, and their trauma history is their backpack. And we want to be careful not to like push clients upstairs or like run ahead of them and yell like, why aren't you coming faster? Or to take their backpack away from them. It's to kind of support them in being able to walk that staircase at a pace that makes sense, and taking things out of their backpack whenever they're ready. So Marie and I had a lot of fun in putting this together, and some debates and interesting discussions on notes on language. Language has a lot of power, but sometimes we don't always know what the right language is. So we're each going to offer a bit of a perspective on language.
Thank you. So like Cara said, language has power, words have power, and they help us identify parts of ourselves, and they also are tools that we use to communicate to others. So I'm going to talk about language in the realm of drug use, and I'm just going to say that like, if you're using some terms, it doesn't mean they're wrong. You know, it is language that is widely used by many communities. And I'm not going to say that it's wrong, perhaps just maybe put forth that it's a little outdated. You know, like I always say this to folks is like, we update our cell phones like every 6 months. We're constantly updating, getting new operating systems. And I think we need to do the same with our lexicon. We need to kind of keep updating and changing things so they're more affirming. So earlier in my bio, and my bio is like really old, I realized I must have said that to you a while ago because I'm actually the communications manager now. So I've had a promotion, so that's wonderful. I identify as a recovered addict and alcoholic. Those are the words that I found power in. They're affirming to me. They help me understand myself. And that's how I identify. I will never put those labels on someone else. I will never call somebody an addict or an alcoholic. There is a lot of stigma attached to those words, and many people feel them. They're not affirming. They feel unsafe. And so I use person first language. Lots of people talk about it. It's about putting the person first before the symptom or the condition or the behavior. So when I'm speaking of people who use drugs, I say just that. This is a person who uses drugs. This is a member of the drug using community. I will never label somebody an addict and an alcoholic. Education and in health, it's all about addictions, you know, and that word is used, and I'm not going to tell you all you're wrong. I'm just going to encourage you to maybe be a little bit more open-minded, especially when you're talking to people you're describing. Like, it's just a person who uses drugs. It removes a lot of stigma and it supports care. Another thing is overdose versus drug poisoning. Again, it's like Overdose Awareness Day. You know, overdose is this word we hear a lot of. But like, think about this. When someone consumes too much alcohol, we call it an alcohol poisoning. When someone consumes too much of a drug, we call it an overdose. The difference may seem slight, but it actually says a lot about how society perceives people who use drugs. A drug poisoning is an accurate term for what's happening within the body, whereas overdose means to administer too much medication in too large of a dose, which puts the onus on the person. Right now, we have the most toxic drug supply we've ever seen. It's going to, street drugs and illegal drugs are continuing to be made in unregulated spaces, in unsafe ways. So our community members don't know what they're taking or how much they're taking. So it's a poisoning. So even if you change just slight language like that, it's going to really help reduce stigma. Another thing I will talk about is homelessness. Homeless community members, homeless people has been something that those are the terms that we refer to people who live outside. But I encourage and I use the words unhoused or houseless folks, because our Albertans, whether what city you're in, the people who live outside are not without homes. Their homes are the cities they live in, the neighborhoods they are residents of. They're just without four walls and a roof. They're just without a house. So unhoused, houseless, drug poisoning, and people who use drugs, or a member of the drug using community, which I think sounds really lovely because the drug using community is wonderful. So that's kind of my thoughts around language. I got a lot of it, but we don't have a lot of time.
And I share a lot of similar sentiments with Marie. I think where we differ a little bit is I think kind of the conceptualization of addiction for me is not about the substance or the behavior that people engage in. It's about how it's used. So in my work, I talk about addiction as an unconscious use of external stuff to fill the role that internal stuff should be doing. So I don't care what it is. It could be exercise, it could be sex, it could be food. Like there's lots of positive things that people can use in unhealthy ways, either unconsciously or to kind of deal with their internal stuff externally. And I find some power in the word addiction and in the work that I've done with clients, many have as well, to kind of separate my conscious choices around drug use, which people have a right to do, as compared to something that isn't serving them, that maybe they want to start to explore some change around. So that's our language spiel. So stepping into next so we know what trauma-informed care is. We sort of understand a little bit about language. So where does it go wrong? Marie and I had a chat about kind of when something goes awry in trauma-informed care or care, where does that come from? And we the literature and both of our experiences boil down to personal bias or stigma. Again, not necessarily purposeful. There's a lot sort of under the surface that we're maybe not aware of, as well as some structural and educational bias and stigma. Lack of knowledge or misunderstanding of knowledge. Sometimes we know just enough to use it in a not great way, as well as I think big ones in helping professions are burnout, lack of empathy, often secondary to burnout, and fear. So I think we have a lot of well-meaning providers that are trying to do great work because they care, but I think we can often accidentally take some agency away or accidentally kind of fall into some of our own biases through kind of some of these mechanisms. And I think sort of one example that I have from my life is, so I have mast cell activation syndrome. I react to pain medications. So I can't take Tylenol, Advil, aspirin, anything. So when I have pain, I do everything I can to manage it on my own. But the only thing that I can take without having a reaction to is fentanyl. And I bet you can imagine how good it is when you go to the emergency room asking for fentanyl and nothing else will do. And I understand the perspective of the healthcare providers that are trying to assist me. And I often get labeled as drug seeking. And in all fairness, I am. I'm going to the emergency room for the sole purpose of getting fentanyl. So they're correct. But there's a lot of understanding around why and lack of other options and things like that. And I've been escorted out of emergency by security. And then because I've had these experiences, I try to over-explain, which then also doesn't go well. I've gone in with a note from a specialist and been accused of forging a note or impersonating a medical provider. It hasn't gone well. And I'm white. I'm well-spoken, highly educated, good advocate for myself. And if that's my experience in that setting, where really sort of the only bias factor I have going against me is that I'm female, I can only imagine what goes on for other people. And that makes it that I really believe my clients' stories when they tell me some things that happen, because I've been there myself and I don't have some of the same kind of factors working against me as they do. Anything you wanted to add for?
Yeah, I'm going to talk a little bit about structural stigma, and I'm going to talk about a story that actually is like has a good outcome. So a lot of my pals are trans and gender diverse, and often my community goes by a different name than they were given at birth, and the name prior is called their dead name. And to get that name off healthcare records and your health card is super, super hard. So continually, when they're accessing healthcare, they will be misgendered and they will be dead named. And I heard a lovely story of my friend got a new doctor, and when they were sitting down, the doctor misgendered them and used their dead name, and my friend advocated for themselves. And often the response isn't super great, but they were met with such empathy and understanding. And the doctor's like, wow, that must be really hard for you. I'm going to assure on all my records in my clinic that it uses the appropriate name, that it is your appropriate gender, right? And so it just was like, yes, I don't think they can go and share, because like structural stigma is like the policies in like healthcare and social services and stuff that is actually really hard to change, but it does affect the care that we receive. And so this doctor's like, I'm going to support you. I'm going to make sure that this space is safer. I'm going to use your correct name. I'm going to use your correct gender marker. And like, I don't hear about that too often. It's actually just a lot of dysphoria when my community goes out. So like, those structures exist, but there are people in healthcare that are pushing up against that and are willing to take the time to really change things. So when we were chatting about that, I was like, I actually have a really good story. And I don't have a ton of really good stories, but that was one of them.
Which leads really nicely into some antidotes and how do we mush against that?
Oh, this is me, right? Okay. This is our first time co-presenting, so we get a lot of grace, y'all. Okay, so what to do when we make mistakes, like some antidotes to such. So these are just like our buzzwords: curiosity, openness, education, creativity, and tenderness. And then I'll talk a little bit about this. So curiosity, to be like, hey, like what, like if someone, you can tell maybe a person has told you that you have hurt them, you've harmed them with your language, or maybe you can tell that you have not been using trauma-informed care, or whatever the situation is, to be curious, like, what just happened there? Was it my own internal biases? Was it something, one of my beliefs that was passed down through me through parenting or society or my own experiences, like, did I make a mistake because of what? Like, it's just to be curious, right? And openness to the fact that that goes along with tenderness, right? Like, I think that we all need to be really kind to ourselves. I think sometimes, and I could imagine for all you healthcare providers and doctors and psychologists, that like, there's this sense that you're supposed to know everything and that, like mistakes aren't allowed. And I actually think that you need to be really tender with yourself and be like, like, I'm just a person. I'm allowed to make mistakes. It's cool if I do. And then also tenderness and kindness and compassion for the person that you are caring for. Educate yourself, on best practices. I'm a firm believer in like peers. Like, there's a lot of research, and I'm just going to plug one of ours, but there's a lot of research being done about community by the community, right? And so we're doing one, it's called Karma, and it is a community-based peer research project that we are leading in partnership with Habitus and the University of Calgary. Thank you. And its prime focus is to look how cannabis use impacts mental health or underrepresented marginalized communities, right? So there's a lot of this like research and these studies and this education that is accessible to folks, especially peer-led, peer research, peer-reviewed is pretty wonderful, I think. I think that's all I got for this one.
Awesome. Okay, so we'd like you to do a little digging in, and there's no right answers. There's no shamey blamey. We're going to embrace that tenderness that Marie just talked about. So I want you to read through our case study here. And then you're going to take kind of a minute. And I believe one of our lovely people who work the technology, because I don't know how, will help us with a 1 minute timer, where you sort of have a minute to reflect. I encourage you to write a couple things down as well. And then after sort of the 1 minute self-reflection, you're going to go into small groups and breakout rooms. And I'd like you guys to chat about kind of what you see, what you think, what's coming up for you. And basically the biggest question is how would you go about kind of supporting this patient? And then we're going to review this again later on as well. So take a minute to sort of think and reflect for yourself, and then join your breakout rooms and chat with your crew a little bit. So we're going to kind of give some suggestions and creative solutions to some substance use stuff. And I'm going to hand it over to Marie first.
So whenever I talk about folks always associate harm reduction with substance use. And I think that is a good area of harm reduction, but like, you know, there's a lot of stigma attached to harm reduction. There's a lot of fear. There's a lot of misunderstanding, right? And like, I always tell folks is that like, we are already engaging in harm reduction. If you wear a seatbelt, if you wear a condom, if you wear a bike helmet, you're already practicing harm reduction. So harm reduction is like practices, policies, procedures, and often even places that aim to reduce harms. Trauma-informed care is a total form of harm reduction. It sends the message that people are of value regardless of their experiences and choices. And I always think like the major thing about trauma-informed care is that it's the understanding that like underinvested communities or other marginalized communities or people are traumatized. I think that's like the main thing is that they actually have suffered trauma. So if we're providing care that aims to like mitigate harm and minimize trauma, we are actively engaging in harm reduction. So that's kind of my little blurb on harm reduction. And then we're going to talk a little bit about this. Again, I could gab forever, and I actually minimize my notes because I have so much that I gab about. So breaking down myths rooted in misinformation and stigma help everyone shift perspectives around harm reduction to align with the facts of the matter and take steps towards effectively and compassionately finding solutions. There are a lot of myths out there around harm reduction, and I'm just going to come at you with some facts and some statistics. I just kind of pulled my favorite ones. So I'm just going to read some of the common ones, and this is a lot that we hear in media, and it is really fear-based is often what I say. So some myths that we hear are harm reduction practices, supervised consumption sites, and policies like decriminalization are enabling drug use. So it's encouraging folks to use, and it's saying use more, you know, it's enabling drug use. Harm reduction and supervised consumption sites will attract more people who use drugs along with crime into a neighborhood, right? It's going to bring more people loitering. It's going to bring needle debris. It's going to be a lot of open use, like a lot of open drug use in your community. That's what we hear. And we're wasting taxpayers' money allowing people to use drugs when we support harm reduction and decriminalization. So let's just talk about some facts. So decriminalization. We know, like this is evidence-based, there are countries, cities, states around the world that have already decriminalized drugs. And in Portugal was one of the first, and in 2001, that's when they decriminalized. And since then, levels of drug use are way below European average. Drug use has actually declined among people aged 15 to 24. That's the population at most risk of initiating drug use, and rates of dependent drug use has actually decreased. So is it enabling drug use, or is I don't think so. And like the facts don't say it is. And then we're going to talk about Vancouver. So unfortunately, there isn't a lot of information around, there is some about our SESs here in Alberta, but there's not a lot of recent, we just got something about, anyways, I'm going on a caveat. So I'm going to talk about Insight. Insight was Canada's first supervised consumption site in the downtown east side of Vancouver. It is a remarkable place. So among users of Insight, 71% of them reported fewer outdoor injections. So there's actually way less people using drugs outdoors, and 56% of them reported less unsafe needle disposal. So it's actually cleaning up needle debris and encouraging people not to use outside. And 1 year after Insight opened up, there was no increase in drug trafficking, assaults, or robberies, and there was a decline in vehicle break-ins. And now I'm going to talk about Switzerland because I would talk about taxpayers' daughter, and Switzerland is doing the deal. They are so harm reduction focused. And so Switzerland has safe supply. And that is the word that we hear about all the time. My organization advocates for it a lot. I mentioned earlier that illegal drugs are being made in unregular places, in unsafe spaces, and are really toxic. So Switzerland has the heroin-assisted treatment program. And when it was implemented, home thefts dropped by 98%. Like, that's remarkable. And also, when the heroin assisted treatment was implemented, HIV infections dropped by 84%. And it cost around $15,000 a year to treat a person in Canada with HIV. So imagine the money that we could save if we even just started to minimize HIV infections, right? Let alone people's quality of life. So harm reduction saves taxpayers money. It doesn't enable drug use, and in some cases it decreases drug use, and it doesn't increase crime or loitering or public drug use. So those are the facts, and they're proven because it's happening over in other places all around the world.
Amazing, thank you. So this is sort of my world, and because I'm a nerd, this is what I did in my spare time. So I designed a model for the relationship between adverse childhood events and intergenerational trauma and chronic disease and those disease outcomes. And we won't, so little plug, join us on May 12th to dive into this model a bit more, but then figure out how to actually use it. So I designed a workbook for primary care around this model. And we'll talk about that on the 12th. But for tonight, the basic idea is that childhood adversity leads to chronic disease through different pathways. The pathway we're going to talk about most tonight is the behavioral mechanisms pathway, because that's where a lot of the addiction stuff is. So people engage in substance use and use of external things for a reason. Often they are trying to cope. And though we may not love that it's substances, that might be what's getting this person through the day. Coping is coping, even if we don't like the actual mechanism. We'll talk a little bit about maybe if there's some ways to move that if a client is ready to do that work. Yeah, and then this just sort of gives a breakdown of the different areas in that model and places that you could intervene and kind of what that would look like, depending on which area the model resonates most for someone. Again, we'll talk about this more on the 12th. Little teaser, you have to come hang out with me again. But for tonight, the big areas that I want to talk about is motivational interviewing, behavior change, and harm reduction creative. So Marie gave a really awesome summary of what that looks like with her organization and the literature behind it. And I would encourage you to get creative with harm reduction. So take, for example, a client who maybe they smoke and they're not ready to stop smoking. That's something either they're not ready to make the change, they feel like it would be too hard, but they recognize that it is having impacts on their health. So some things that I've done with clients is, okay, so if your smoking is sort of filling up the not good towards my health bucket, maybe we can do some things to fill up the health bucket. So one that I commonly do is maybe 3 or 4 days a week, you go for a 10-minute run. Smoking is not good for your lungs. Go for a run to kind of try to counterbalance that. And obviously that's not the way it works, but the idea is somebody's putting something back because something's taken out to try to mitigate some of the harm that smoking is doing. And often what happens, especially if it's a cardio thing that someone's doing, is they recognize it's harder to breathe. Maybe they start to really like that activity and want to do it better. And then they kind of make the choice on their own to stop smoking or decrease their smoking because they're liking that thing that's filling up their health bucket and they like the way that that feels. But instead of stop smoking, that's gross, it's okay, what can we do to mitigate some of the things around smoking when you're ready? And then often sort of that power of health and power of positivity and power of starting to feel better starts to help support them in making those changes naturally. So I encourage you to get really creative around your harm reduction. Harm reduction can look at anything for something that fills the health bucket, as well as the stuff that Marie talked about for sort of decreasing risk about certain activities and choices. Also, motivational interviewing is used a lot in addictions work, and I think that's great. What I would encourage is I've seen it sort of used in not such a great way to sort of build some, not intentionally, but build some shame around what that person's doing. So you say that you want to be healthy and take care of yourself, but you're doing all of this. So is that really, does that really feel good? And that's not an awesome way to go about it. The idea with motivational interviewing is it's what stage of change are you at? What are you ready for? How can I support those needs given what you're ready for or not ready for? And when you are ready to kind of make some changes, how do we explore what your values are and what's important for you and what you want for yourself, and see if where your substance use fits in with that or doesn't? And one of the questions I like to start with is like, what's good about drinking or doing drugs? And it's because like people don't do things for no reason. They're not stupid. So if I can learn more about what value that brings to their life, what that's helpful for, we just have a much richer conversation. And then the other piece around the behavior change stuff that I think is kind of fun to be creative with is change is hard. Like it's hard for everybody. And when we look at like weight loss, drinking more water, taking your medication regularly, and like stop using substances, it takes on average 7 tries where you make some progress in that area and then you kind of go backwards or relapse. Those aren't great words, but and so change is hard and things happen, and it's sort of like a go back and figure things out. So I like to frame it as, okay, you're starting a business. Does that mean that you have to have everything figured out to start that business? Or is it figure out a certain piece and then let's give it a go and try it and see what happens and adjust and iterate and make changes? And what if we treated your change in substance use the same way? What if you sort of did your best to plan some stuff, but you just jumped in and gave it a go? And then we learned what went well, what didn't, what do we need to tweak? So treat it like you're an entrepreneur in your own substance use or any other changes that you want to make in your life, not like I have to do this and it has to be perfect now, otherwise I'm a failure. So that's some kind of strategies and ways to get creative with supporting clients and making change, but in ways that make sense for what we know of change and substance use. And yeah.
And yeah.
Sorry, same thing. I could go on for forever and I'm trying really hard not to. So we're going to circle back to relationship-y stuff again, and we're going to talk about when you screw up, because you're gonna.
That's me?
Yeah.
Or is it me? Oh gosh. Okay. And something that I'm just like thinking to myself as we start going through this, like our language has been really abstinence-based, and that isn't wrong, right? Like what to do when your client or your person wants to change or they're interested. Like we have to harm reduction. And I think is at its essence is like, we need to accept if people maybe don't want to change, and how do we still provide care for them? So like me, I'm an abstinence-based person. Like I wanted to get sober. I was dying, and I that's what was a right fit for me. But we have to really let go of expectations that this person will change or does want to quit smoking. We still need to care for them, and as much as we can, even if like they are going to make changes. That's kind of my thing. Okay. What to do when you screw up? Is the next one? I thought this was you, if I'm honest, and I thought it was authentic apologies.
We can switcheroo. I'm cool with that.
Yeah, do that.
I'm going to talk about when you screw up.
What to do when you screw up.
So kind of that kindness and self-tenderness that Marie was talking about earlier, like you are going to screw up. I had a mentor that said one of the most profound things to me in my career, which is don't aim for perfection, aim to be good at repair. Because you can actually be successful at the second one. You're never going to be successful at the first one. So accept that you're going to mess up, and that's okay. And so our little pictures here show kind of like figure out what went awry. How did you screw up? What did that look like? What happened around it? Be curious, and don't be afraid to look into that, right? If we're being kind with ourselves that it's okay to screw up, then it's easier to take a look at what happened and be curious about that. And then maybe sort of generate some different ideas. Like we said, understand a bit about what happened. What are my biases? What are some of the system biases? Am I fried? Maybe there's a knowledge gap. What are some ideas I can generate around what happened, and coming up with solutions? And then sort of the biggest piece is be kind to yourself, be kind to others. And then what can we do to change? Like, what does that look like? So Marie provided a great example earlier of a health provider that misgendered and used a dead name. recognized it, owned it, was curious, oh, there's some system stuff here. What can we do to make sure that this doesn't happen again? What can I do within my clinic? And is there anything I can do within the system that can maybe help to foster change?
Oh yes, the changing of the butterfly. I like that.
Right?
Picture.
Like that
that's
image?
good.
Yeah,
It's
yeah.
good. Okay, authentic apologies. Yeah. So again, we're talking about like understanding, like empathy, like actually perhaps putting yourself in that person's shoes. And maybe you've never had the same experience, but perhaps you've had something similar, you know, own what's yours and actually say, sorry, I'm going to talk about that. Like apologizing, like an authentic apology actually means we need to say sorry. So I'm going to talk about that a little bit. So we talk about like, we're like obviously like feely people. Let's talk about feelings and be tenderness and compassionate. I always strongly encourage us to remember that we are just people and we're doing the best we can with what we have, and we are going to make mistakes. And if we can humble ourselves and just like be cool with making mistakes, we are going to be able to give a far more authentic apology. Really important to look at outcome over intent, you know, like we may have the best intentions and we just may want to support and care and make that person feel affirmed. And that's our goal. And maybe the complete opposite happens, right? What is the outcome? We can't just be like, well, I was trying to do this and I was hoping, right? It's like, we really need to affirm the person's experience that we did our best, but we didn't quite get there, and that's okay. When we say sorry, like legit apologize. Don't be like, I'm really sorry you feel that way. I've had so many people apologize to me that way. And professionals be like, I'm really sorry you feel that way. That sucks. That is not affirming. That is just like put such a distance between you and that person. It creates more of a distance. It separates you. And avoid using but, you know, like, I'm really sorry this happened, but I was trying. Again, you're making the apology about yourself. And we've talked about this a lot, going on like a fact-finding mission, look inward. Is it our own bias? Are we using outdated language? Like what actually happened? And we have to remember that like we may do everything right. We may do everything within our power to create a safer space, to provide care. We've done the research, but that person still just may get hurt because they're dealing with trauma. So apologize, be super important, practice empathy, affirm, and then like honestly take a look at like, like what just happened there? What did I do to make the situation not ideal?
I think that was an awesome summary. So often when a client brings up something that I've done or that they're uncomfortable with, the first thing that I do, not externally, because that's not cool, but internally, I celebrate. Like how amazing this person feels comfortable enough with me and has enough self-worth for themselves that they're willing to tell me that I made a mistake. So internally, I'm like, yay. And then I try to like ask questions. Okay, tell me more about that. What happened? Like, what was it? Something I said? Was it body language? Was it tone? Like, tell me more about the impact that had on you. Like I try to ask questions that I really understand, which shows that I'm trying to be genuine about this. And so an example that I have that comes up often is I work with clients who have a history of trauma. And often our relationships aren't safe for them. Over time, our relationship becomes at least predictable, if not safe. So, and if there's been trauma at the hands of like caregivers or authority figures, those clients tend to get really good at feeling out how that caregiver is doing because that's what they need to do to keep themselves safe. So if I'm off on a day, clients know, and often they know before I do. So I've had clients be like, what's up with you today? Or like, you're not yourself today. Or like, I'm not really getting what I need. And at first I was like, no, like, I'm like, what are you talking about? Like that's not what's happening. Or I didn't say that, or I didn't mean that. And then I kind of reflected, like, they're probably picking up that I'm off somehow in a way that maybe I don't even recognize. But because they've had to be so attuned to that, they recognize it. So even if I don't feel off, I apologize. I say, thank you for letting me know. I guess I must be off today. I'm not meaning like that. I'm not reacting to something about you or it isn't about you. I brought some stuff in that maybe I thought I was managing better. And that shouldn't have affected your appointment with me. I apologize. And if it happens a couple times, we might explore like, you're super attuned when other people are off. I'm a human being. I'm going to have off days, that impacts you. So how do we manage this so that you feel okay in our relationship? And I'm taking accountability for what's mine, but that we can continue working together knowing that I'm a human and I'm going to have some off days. What does that look like? So that's kind of us like circling back and figuring out how are we going to work together moving forward after something's happened. And I would reflect that often if your clients are reflecting something was off, it was because it was off, even if you don't feel off. Like the number of times I've gotten like a cold the next day where I'm like, oh, they just like knew it before I did, is pretty amazing. Okay, cool. So we're gonna stop jibber jabbering a little bit and we're gonna do some more like togetherness work. So we're gonna go back to our case study, kind of thinking about some of the stuff that came up that Marie and I jibber jabbered over the last little bit. Reflect on your case study again. Give yourself a minute again to do that reflection. And I'd like you to think about anything you would do differently from kind of what you were thinking before, any spaces where your bias might come in or where systemic bias might come in. And are there spaces in this that you see where like a fracture or relationship rupture could occur? And what might that look like if you were to repair that? So I know that's a lot of questions. So if you just want to manage like one or two of those cognitively, that's okay. But basically reflect on the case again. Think about what's similar or different from what you would do before. A minute to do some thinking on your own, 5 minutes with your group, and then we're going to come back together as a crew and do some debriefing. So maybe as people come back, I would like to stop sharing so that I can see like the chats and stuff. But maybe just we want to, before we dive into the convo, we want to say thank you. Our email addresses are on there and we're happy to be contacted. And yeah, let's have some fun discussion. So people can pop some things into the chat. But I'd love to hear like, yeah, what were some of the conversations? What do people see? Were there any sort of like before and like first thoughts versus second thoughts? And you can unmute yourself or put stuff in the chat however you feel comfortable. Drop in some knowledge on us.
I think in our group, we were all like, in the second time around, I think Susan said she'd sit on her hands so her mouth didn't work and just listen. Like don't go in there with that preconceived idea. And I sort of looked at the case and went, I'm worried about this, and this, and there's those presumptions. And Ted articulated, be curious, find out what's going on, and find out what the request is. But there's always that worry in the back of our mind, and those implicit biases. So I'll let others in their group explain what they heard.
Just going to jump on that last point with implicit biases. One of the things that was brought up in our group was that his exercise may be his form of coping, and that may be his new addiction. And often we don't think about that as a bad thing, but certainly for him, that could be a huge factor in terms of him wanting something to help with pain because he doesn't have his form of coping right now.
Yeah. So how do we recognize that might be a coping thing? So him not having it is a big deal, right? Like we might think like, oh, you can't get your gains on for a couple of weeks, like whatever, but maybe it is a really big deal. And being mindful that, yeah, how do we support things that are good for someone, but also be mindful that we can also use things other than substances to fill needs. And if that's the case, what do we do with that? How do we actually be supportive, but also how do we acknowledge like his right to self-determination and right to choices, and balance that. I see a comment reaffirming listening to the recommendations, particularly being curious. Yeah, asking for permission to find out more. Awesome. I think you guys did great with it. The idea in there is like, okay, there's some things where we go, ooh, but there's also like areas of strength that we want to be excited about and acknowledge. And He's wondering about pain medication, hesitant about physio. Okay, why is that? Tell me more. Not like no pain medication, do physio. It's like, let's like, maybe he doesn't have benefits for physio. Maybe he can't take time off work. Right? Like, what's going on that there's the hesitancy there? And kind of, yeah, acknowledging that there's areas of risk that we want to be aware of, acknowledging there's lots of areas of strength. It's about, yeah, kind of being curious.
And I also think too, because did we say how old he was? Was he 26?
Yeah.
And then he had, and with his relationship with substances, was it problematic and he stopped at 20?
Yes, he used them to cope. We didn't necessarily call them.
Right. So this is another thing. We can't all make, like, nothing makes drug use inherently bad. Like, people use drugs because it's great, right? Like, it's not always bad. So I think it would be really interesting to find out, like, what is his relationship with substances? You know, like, is he a casual drug user? Because that's totally fine. I mean, weed's legalized now anyways. So we can't just be like, oh, maybe it was problematic, and now we have to have fear that if we give him something, it would be terrible. I think that we just need to do a little bit more research. Because even if it is some big, huge injury, like, opiates are used for pain management, it doesn't mean he's going to become dependent on them, you know? I just know that if you ever say, and I have a wonderful doctor, but if you ever say you have a history of struggle or problematic drug use, you better watch out, because and for me, I'm stoked because I don't want to be prescribed nothing, but like, yeah, it takes away our ability to be honest with healthcare providers, because we fear if we actually need something, or if we are honest, what does that mean? What kind of care? Are they going to be hesitant? Or, you know, like, it's a legit thing.
Yeah. And I think that's where that be curious, be honest, listen to what your patient is telling you or your client is telling you, and work together. Yeah, and Brandy put in the chat, instead of assumptions, listen and ask. Exactly. Be curious, and it's those implicit biases that you have to self-reflect before you walk in there. And so I know we've gone over time. It's 8:33. We really appreciate you guys coming and talking and sharing your email. And just want to let everyone know that we're doing a deeper dive into some of those clinical tools for primary care in a couple of weeks. Marie and Kara, thank you so much. And I just want to plug our Echo series for chronic pain next Wednesday, 4:30. So where we present a case and discuss it with our team from the Calgary Chronic Pain Center and our physicians from Boyle Macaulay. So really appreciate everyone attending tonight, and thank you so much.